بسم الله الرحمن الرحيم. طلبتنا الأعزاء, our lecture today is regarding pathology of the esophagus, diseases of the esophagus. The esophagus, brief anatomical points. This is the cervical part of the esophagus. This is the thoracic part of the muscular tube, that is the esophagus, and relation to the major vessels in the chest and the anterior trachea. And this is the abdominal part of the esophagus. The wall of the esophagus is histologically is composed of 4 layers: the mucosa, the submucosa with mucus-secreting glands, and the muscular wall, and the adventitia. To start with congenital anomalies regarding this organ, regarding the esophagus, in general, the diseases or causes of esophageal diseases can be infectious, can be autoimmune, can be anatomical defect or congenital anomalies, irritative processes, neoplastic process, and so on. To start with the congenital anomalies, atresia and fistula. Atresia and fistula. Atresia means obliteration of the lumen. Fistula is connection of the mucosal wall of the esophagus to another epithelial surface. Maybe incompatible with life. Different types of this atresia and fistula can be seen. The atresia, the esophagus is replaced by thin cord that is obliterated and can be connected with the trachea, or maybe associated with another heart anomalies and other congenital anomalies. If there is association with tracheal fistula, there are many pulmonary symptoms can occur, including aspiration pneumonia, suffocation, fluid and electrolyte imbalance. Stenosis, another congenital anomaly, is a stenosis. Stenosis means narrowing of the lumen, narrowing of the wall, webs and rings. Webs means eccentric fold of mucosa and submucosa, where our rings are circumferential, complete circumferential thickening of the mucosa and submucosa. There is a trade which is preneoplastic or premalignant disorder called Plummer-Vinson syndrome. Plummer-Vinson syndrome. It is a trade made up of 3 clinical features or 3 settings, including adult female with iron deficiency anemia, adult and or postmenopausal women with iron deficiency anemia, dysphagia, and related to dysphagia and upper esophageal web. This is one of the risk factors for development of squamous cell carcinoma, usually pharyngeal and upper cervical squamous cell carcinoma, Plummer-Vinson syndrome. This is what we mean by esophageal web. I say it is an eccentric thickening or band in one side, in one aspect of the lumen of the esophagus, mucosal and submucosal fold, called esophageal web. If it is associated with dysphagia, in a female with iron deficiency anemia, it is called Plummer-Vinson syndrome, which is a risk factor for pharyngeal and upper esophageal squamous cell cancer. Stenosis or ring. Stenosis is narrowing of the lumen, or ring, it is complete or circumferential ring or circumferential thickening of the mucosa and submucosa of the lumen of the esophageal wall. The main congenital anomaly, including atresia and fistula, can appear in different settings. One of them is the formation of the commonest one, about 86.5 is 86.5% is composed of upper esophageal atresia, atretic cord, upper esophageal atresia with lower tracheoesophageal fistula. This is the most common. Congenital anomaly. Many of these congenital anomalies can be incompatible with life if they are not corrected surgically, can be associated with suffocation pneumonia and aspiration pneumonia and chemical pneumonitis. Here, in this type, the less common types can be associated, as in this more evident picture. Here, two upper and lower atretic cords without tracheoesophageal fistula. In this type, the type B, there is only upper tracheoesophageal fistula without atresia. The most common one is upper atretic cord, esophageal cord, and lower tracheoesophageal fistula. Here, the commonest presentation of the baby or infant is presence of projectile vomiting after feeding due to regurgitation of milk from this atretic esophageal cord. The other one is only atretic esophageal cord without fistula, and here common fistula, common fistula, tracheoesophageal fistula without atresia. The most common one is type C, upper atretic cord, upper esophageal atresia with lower tracheoesophageal fistula. The symptoms that are associated with esophageal disease, many symptoms, and the most common or cardinal symptom of esophageal and oropharyngeal disorders or diseases is difficulty in or disruption of or the difficulty in swallowing, called dysphagia. Dysphagia is difficulty in swallowing. It can be categorized into oropharyngeal or esophageal depending on the phase involved. Another feature is odynophagia, that is painful swallowing or pain during swallowing. Many other features associated with esophageal disorder or diseases, including heartburn, including food regurgitation, especially on lying down horizontal, heartburn that can be sometimes missed as cardiac disease or cardiac ischemia. Another signs and symptoms, including gastrointestinal bleeding, including weight loss, iron deficiency, and so on. Dysphagia can be divided into two types according to the causative agent. Can be structural or mechanical, as in congenital anomalies we mentioned previously in the previous slides. Structural or mechanical, like a web or like a band or stenosis or atresia. This is a structural or anatomical or mechanical obstruction result in dysphagia. Or it can be motor or neuromuscular, related to failure of ganglion cells or failure of inhibitory neurons, or also can be due to infiltration of the nerve ganglia by neoplasm or amyloidosis or protozoan infection. So it is related, dysphagia related to uncoordinated neuromuscular or nerve function. Mechanical disorders, the most common causes of esophageal dysphagia is mechanical disorder rather than motor. Mechanical is mainly related to peptic disease or peptic stricture. Peptic stricture, that is the most common cause of is related to reflux esophagitis and gastroesophageal reflux disease and its complication. The process is slowly progressive with associated chronic heartburn and sometimes upper GIT bleeding, pain, and that is aggravated by eating, and it is associated with inflammation and ulceration and other reparative process. Mechanical disorder, or also esophageal cancer. This is a rapidly progressive cause of esophageal atresia. And we will mention the risk factors and causative and premalignant changes of esophageal cancer in the next slides. Motor disorder, to a lesser extent, are causes of esophageal dysphagia, 10 to 15% only. A disease or disorder called achalasia or cardiospasm, achalasia, esophageal spasm or diffuse esophageal spasm, scleroderma or multiple sclerosis. This is an autoimmune disease of the connective tissue. Achalasia, that is that is motor type of or cause or motor cause of esophageal dysphagia. Achalasia, or called cardiospasm or esophageal peristalsis. The mechanism here is absent esophageal body peristalsis, incomplete lower esophageal sphincter relaxation, lower esophageal sphincter hypertension, or increase in the lower esophageal sphincter tone. The causes of achalasia is either idiopathic or called primary, of unknown etiology, unknown cause. It is related to degeneration of the motor neuron of the ganglion cells in the myenteric plexus in the wall of the esophagus. That is the idiopathic, or it can be related to neoplasm infiltrating the ganglia and other infiltrative disorders like amyloidosis or Chagas disease, that is protozoal infection involving the wall and affecting the motor neuron or ganglion cells. This will result in loss of ganglion cells in the myenteric plexus of the esophagus. The ganglion cells in the myenteric plexus will be damaged, will be degenerated, result in loss of inhibitory neuron or inhibitory mechanism. Esophageal inhibitory mechanism will be lost. So there will be stenosis of the lower end of the esophagus. What is the cause behind primary achalasia? It is of multiple, or it is of unknown etiology. It can be degenerative. or it can be autoimmune inflammatory process triggered by viral infection or neurodegenerative disease or related to genetic predisposition or other inflammatory and infective process. The dysphagia is gradually progressive to solid and liquid, with associated chest pain in some patients and nocturnal aspiration and weight loss. Nocturnal aspiration or regurgitation of food, especially on lying horizontal, and with associated weight loss. This is the primary type. Diagnosis of achalasia is by barium swallow, that is after ingestion of contrast, X-ray will be taken to demonstrate the stenosis, and endoscopy or OGD, called OGD, esophageal esophagogastroduodenoscopy to exclude underlying neoplasm and biopsy taking if necessary. This is the X-ray, or what we call barium swallow. Barium or contrast media will be ingested by the patient, and X-ray will be taken to demonstrate the upper narrowing due to upper esophageal dilatation and the gradual narrowing or tapering, sudden tapering of the lumen of the esophagus. That is what we call it bird peak sign or rat tail sign. This is the stomach and this is the esophagus, and there is a sudden or intervening tapering or narrowing of the lumen related to failure of relaxation and a peristaltic movement associated with upper esophageal dilatation above the stenotic segment and narrowing, severe narrowing here. So there is muscular hypertrophy and dilatation upward, and stenosis related to failure of relaxation, increased lower esophageal sphincter tone, and lack of peristaltic movement due to degeneration of the ganglion cells in the mesenteric plexus in the lumen or in the muscle layer of the esophageal wall. Hiatal hernia, this is also anatomical defect, diaphragmatic muscular defect, widening of the space through which the lower esophagus passes through the diaphragm into the abdomen. In these cases, part of the stomach or part of the wall of the stomach will be bulged out upward into the thorax. It is of two types. The most common type called sliding or axial type due to protrusion of the stomach above the diaphragm. The paraaxial type, that is about 5%, rare type. Paraesophageal or non-axial, there is a separate part of the wall of the stomach will enter the thorax. Hiatal hernia is anatomical defect of unknown etiology. This is the normal location of the or entry of the esophagus and connection with the stomach and the abdomen, and this is the diaphragm. In hiatal hernia, there is widening of this this opening and bulging of part of the body of the fundus of the stomach into the chest. That is the commonest type, what we call it sliding or axial type of hiatal hernia. This type of muscular defect or anatomical defect can be associated by many symptoms, including regurgitation, heartburn, aspiration pneumonia, and can be corrected surgically. The food can move back to the esophagus, creating burning sensation, heartburn, and sometimes regurgitation of food into the mouth. Another complications are strangulation, that is rotation or twisting of the base of this bulged out part of the stomach, and gangrenous changes. This is the strangulation with obstruction of the blood vessel, result in gangrenous changes, obstruction, ulceration and bleeding, and perforation. Complications of hiatal hernia. Laceration or Mallory-Weiss tear or Mallory-Weiss syndrome. This is a condition resulting it is a result from longitudinal tear of the mucosa and submucosa of the esophagus without laceration or without involvement of the muscular layer. This picture showing you what we mean by Mallory-Weiss laceration, longitudinal tear in the mucosa and submucosa, and exposed here. There is exposure of the muscular coat not involved. The muscular coat is not involved. The main cause is severe vigorous vomiting and result in upper gastrointestinal bleeding, that is hematemesis and maybe melena, heartburn. There are many causes of vomiting, severe vomiting can complicate this lesion, including alcoholism, hyper or bulimia, that is over distended stomach bulimia, also hyperemesis gravidarum, severe vomiting in morning sickness in pregnant female, and many other causes of increased intragastric pressure and severe vomiting. Diverticula. What is diverticulum? Diverticulum is an outpouching of the mucosal or pharyngeal mucosa. Diverticulum is an outpouching of the mucosa. It is either happens in the upper part of the esophagus or called proximal, or in the distal part of the esophagus called distal diverticulum. In the proximal part, it is called Zenker's diverticula. These diverticula resulting from outpouching of the esophageal mucosa through a point of weakness when the transverse and oblique muscles of the pharynx attach to each other or intersect each other. The mucosa of the esophagus will be bulged out through a point of weakness, and they are termed also pharyngoesophageal and are classified as pulsion diverticulum or pulsion diverticula. Pulsion means there is a pushing force or pushing outside from increased intraluminal pressure. So the mucosa of the esophagus will be bulged out or pushed out through a point of weakness in the muscle dissection in the pharynx. So this is a proximal So Zenker's diverticulum or Zenker's diverticula are proximal pharyngeal or pharyngoesophageal diverticula. Whereas the distal type in the lower third of the esophagus, especially at the level of the hilum of the lung, in which there is inflammatory, especially tuberculous lymph node in the lung, in the pulmonary hilum. When there is calcified tuberculous lymph node, these lymph node can, with excessive fibrosis, can tract or can firmly adherent or attached to the esophagus, produces traction diverticula. So there is a force that is firmly attach or firmly pull the esophageal mucosa from outside. So it is called the traction diverticula in the lower third or distal part of the esophagus. Barium swallow showed dilatation, outpouching filled with contrast media in the upper part. So this is the pharyngoesophageal or Zenker's diverticulum. Weakness of the bulging of the mucosa of the esophagus through a point of weakness in the pharyngeal muscles. This is another diagram showed achalasia, in which there is a typical sign called tapering or rat tail or bird peak sign, in which there is a proximal dilatation and lower stenosis, achalasia, primary and secondary. Hiatal hernia, this is the sliding type. Hiatal hernia, this is the sliding type, in which a portion of the stomach bulged out through a point of weakness or widening in the diaphragm. The less common type, in which only part of the wall of the stomach is bulged out, this is called paraesophageal or non-axial type of hiatal hernia. Upper proximal Zenker's diverticulum in the upper third of the esophagus, and lower third traction diverticulum in the lower third of the esophagus, and Mallory West tear or Mallory West lacerations. Esophageal symptoms, signs and symptoms, including heartburn, including upper GIT bleeding, including regurgitation, odynophagia, dysphagia. Many features can be presented with each of these esophageal disorders. Varices. What is varices? Varices are engorged, dilated, tortuous submucosal veins. Occurs due to portal hypertension, that is, increase the blood pressure in the portal circulation, mainly in cirrhotic patients. There is a formation of collateral bypass channel between the portal system and the caval system, the inferior vena cava. So in patients with cirrhosis, there is an increase in portal circulation, so there will be backflow of blood, venous blood, into the systemic circulation, result in engorged, dilated submucosal vessels, submucosal veins in the lower esophagus, and result in severe massive bleeding and massive sudden fatal hemorrhage is the feared complication or consequences. This picture showed you the dilated, tortuous, severely engorged veins, submucosal veins in the lower esophagus, lower third of the esophagus. Here, the microscopically, there is submucosal tortuous dilatation with even rupture to the surface, and this is an angiogram showing dilated tortuous submucosal veins. There are three types or three locations for portal caval anastomosis. The three main locations. The main one is esophageal, lower esophageal submucosal veins, veins around the umbilicus, and veins in the lower part of the rectum, rectal submucosa, that are hemorrhoidal vessels. They are related to portal hypertension. There is increase in blood pressure through the portal circulation. The liver is severely cirrhotic. The blood flow is severely impaired through the hepatic circulation, the portal circulation. So there will be backflow into the systemic circulation, result in these complication called esophageal varices, submucosal dilated tortuous submucosal veins. These dilated veins in the lower esophagus are very susceptible to laceration, rupture, and severe upper GIT bleeding. Massive and sudden rupture can be fatal and should be urgently corrected as surgical emergency by ballooning or by surgical closure of this ruptured vein to stop the severe fatal upper gastrointestinal bleeding. So again, veins are dilated tortuous veins in the lower esophagus, mainly in cirrhotic patient with increased portal circulation. And also these tortuous veins can be seen around the umbilicus and in the lower rectum. Hemorrhoidal vessels, rupture, laceration, and upper GIT bleeding, hematemesis, and melena are fatal, are causes or severe complications due to and should be corrected surgically and urgently. Tortuous dilated submucosal veins related to increased portal hypertension and increased blood pressure through the portal circulation. Okay. Another subject is esophagitis. Esophagitis in general, many etiologies or many causes can result in esophagitis, mainly many causes. First and common is reflux esophagitis, that is caused by reflux disease or acid irritation, gastric acid irritation of the mucosa of the esophagus. Prolonged intubation in comatose patient, in hospitalized patient, intubation may aggravate or encourage secondary bacterial and fungal infections and esophagitis. Irritants to the esophagus, including tobacco, alcohol, acid, alkali, corrosive agents, and so on. Many irritants or excessively hot drinks, and so on. Cytotoxic therapy, radiation therapy can be associated with esophagitis. Viral and fungal infection. Viral includes cytomegalovirus, human papilloma, and herpes virus. Fungal infection, candida is the main fungal cause of fungal esophagitis. These are infections in immune suppressed patient, viral and fungal esophagitis. Microscopically, the gross appearance of esophagus or mucosa with esophagitis is in general features of inflammation, including hyperemia, redness, inflammation, ulceration, edema, and granulation tissue formation. Microscopically, there is eosinophils infiltration and neutrophils and basal cell hyperplasia. Stratified squamous epithelium, normal lining epithelium, and also elongation of the lamina propria papillae due to hyperplasia of the basal cells, and reactive regenerative process and reparative process in esophagitis to repair the damaged and irritated mucosa, elongation of basal cell hyperplasia, and elongation of the lamina propria papillae. Gastroesophageal reflux disease is a common cause of esophagitis. It is related to failure of the lower esophageal sphincter closure and relate in poor closure, and gastric content will re-enter or will be regurgitated and again to the esophagus with its rotating effect due to high acid content into the on the squamous epithelium. Pathogenesis of the gastroesophageal reflux disease or GERD. There will be decreased efficiency or efficacy of the esophageal anti-reflux mechanism, loosening or incomplete closure of the lower esophageal sphincter result in decreased the anti or diminished anti-reflux mechanism, inadequate or slow esophageal clearance of the reflux material, the same, slowness of the esophageal clearance in obese, in increased intra-abdominal pressure, presence of sliding hiatal hernia, presence of this type of anatomical defect. Part of the stomach will be bulged into the thorax, result in re-entering or regurgitation of gastric content into the esophagus. Increased gastric volume, many causes of increased gastric volume, including obesity, central obesity, bulimia, that is over-distended stomach with food, pregnancy, and other causes, reduction in the reparative capacity of esophageal mucosa by protracted exposure to gastric, repeated attacks of damage, of irritation of this gastric juice rich in acid. Repeated exposure of the esophageal mucosa will result in ongoing, chronic, long-standing reparative and inflammatory process, ulceration, erosion, and also in smokers, this reparative capacity will be decreased prominently. Risk factors of gastroesophageal reflux disease. The risk factors of gastroesophageal reflux disease, including obesity. Obese people can develop regurgitation due to increased intra-abdominal pressure and especially central obesity. Pregnancy. Pressure of the gravid uterus on the stomach result in regurgitation or feeling of acid taste in the mouth. Smoking is also impair the reparative capacity of the mucosal epithelium of the stomach and esophagus, both of them. Hiatal hernia, protrusion or bulging of part of the stomach into the chest through a weak widening of the diaphragm, will result in food and rich in acid content with its irritant effect on the esophageal mucosa. Medications. There are certain medications or treatments impair with the or associated with the increased risk of reflux disease, including antihistamine, calcium channel blockers, antidepressant, hypnotics, steroids. These are associated with dilatation or incomplete closure of the lower esophageal sphincter. Zollinger-Ellison syndrome. This is a syndrome in which there is hyperplasia of the cells secreting or excessive gastrin to stimulate the acid secretion. So there are multiple peptic ulcer in the stomach, in the esophagus, and in any part with increase with gastric mucosa or exposure or exposed to acidic gastric juice, duodenum, lower esophagus, and stomach. High blood calcium, increase in the blood calcium will increase the gastrin production. Gastrin, this is a hormone to increase the gastric acid production or stimulate gastric acid production. Scleroderma, this is or systemic sclerosis. This is an autoimmune disorder affecting the connective tissue of the esophagus with resultant esophageal dysmotility and loosening of the esophageal sphincter and resultant gastroesophageal reflux disease. The long-term effect or long-standing effect are severe, including gastrointestinal bleeding, ranging from hematemesis, melena, lower esophageal due to lower esophageal ulceration, esophageal strictures after ulceration and stenosis. Barrett's esophagus. Barrett's esophagus is an ominous pre-malignant change in which there is long-standing exposure of the lower esophageal squamous epithelium, which is sensitive to gastric acid. It will be metaplastic. It will be transformed into intestinal type epithelium, glandular epithelium with goblet cells that are more resistant to acid secretion. These foci of intestinal metaplasia with the time may undergo features of dysplasia or undergo changes of dysplasia that is started as low-grade dysplasia into high-grade dysplasia and even invasive cancer. The type of cancer, complicated gastroesophageal reflux disease, is esophageal adenocarcinoma rather than squamous cell carcinoma because it is arise on a background of intestinal metaplastic glandular epithelium. Barrett's esophagus again occurs in about 11% of patients with reflux disease. 11% of patients with symptomatic patient with reflux disease develop Barrett's esophagus or Barrett's esophagitis. Again, the pathogenesis is prolonged or long-standing recurrent gastroesophageal reflux resulting in inflammation, ulcerations, reepithelialization, repair process, and growth of the stem cells or pluripotential stem cells. Those differentiate to an acidic medium into gastric or intestinal cells. This is called intestinal metaplasia or glandular metaplasia, in which the cells are more resistant to gastric acid. Endoscopy, picture of endoscopy showed the hyperemia in the lower esophagus with red velvety mucosa. The pale areas, these pale gray areas, are the remnant of the squamous epithelium, whereas the reddish velvety are foci of glandular metaplasia, that is Barrett's esophagus or Barrett's esophagitis. This is a pre-malignant condition. Diagram showed that transition. This is the squamous epithelium, and this is the columnar columnar epithelium, metaplastic, and the Zahn line will be merged or will be coincides in the upper part of the gastroesophageal junction. Gastric columnar metaplasia and adenocarcinoma can complicate Barrett esophagitis. This picture showed the replacement here, the squamous epithelium, inflamed, erosion, severely inflamed, and foci of glandular metaplasia rich in goblet cells. These cells with large vacuoles are goblet cells. These cells are more resistant than the squamous epithelium to gastric acid. It is a long-standing complication in patients with Barrett with reflux disease or reflux esophagitis. Eventually, the glandular epithelium or the intestinal metaplastic epithelium will replace the squamous epithelium. Here, there is here's a diagram showed the transition from squamous epithelium, esophagitis, infiltration by inflammatory cells, Barrett, repeated attacks of repair and inflammation and ulceration, long-standing after many years. Esophagitis, there will be replacement of the stratified squamous by columnar epithelium with goblet cells. Dysplastic changes can occur low-grade and high-grade in steps, even into invasive carcinoma or frank carcinoma, glandular formation, and invasive gland or invasive cancer-forming gland, that is adenocarcinoma. So adenocarcinoma, esophageal adenocarcinoma can complicate Barrett esophagitis. Pleomorphic cells in the lower esophagus. These are the squamous metaplastic epithelium. The intestinal metaplastic epithelium, goblet cell forming, and glandular formation. The cells are bizarre looking with pleomorphic nuclei and glandular formation. Another esophageal tumor rather than esophageal adenocarcinoma complicating Barrett esophagitis, benign tumor of the soft tissue of the wall, including leiomyoma, that is benign tumor of the smooth muscle, fibroma, tumor in the stroma, lipoma, adipose tissue mass, benign, hemangioma, vascular tumor in the submucosa or in the wall, neurofibroma, peripheral nerve involvement or nerve involvement by benign tumor, neurofibroma. Another malignant tumors including squamous cell carcinoma, undifferentiated tumor, undifferentiated or poorly differentiated, carcinoid tumor. This is a tumor of neuroendocrine cells that are distributed throughout the gastrointestinal tract with hormonal or humoral, secretion, secretory functions, and certain physiological materials secreted in the stomach, in the esophagus, in the intestine, and so on. Malignant melanoma, melanocytes, can be differentiated from the basal cells and the squamous epithelium of the esophagus to produce malignant tumor, malignant melanoma. Squamous cell carcinoma of the esophagus is also common. Many risk factors different from those of adenocarcinoma complicating Barrett. Risk factors including smoking and alcoholism and their irritating effects and toxic effect to the mucosa. Malnutrition, poverty is a risk factor for squamous cell carcinoma of the esophagus with multiple vitamins deficiency and immune deficiency, especially vitamin A and C. Esophagitis, any type of esophagitis, including chemical esophagitis, prolonged irritating radiation, chemotherapy, and so on, and achalasia also. Achalasia that is a pre-malignant or can predispose to squamous cell carcinoma. High nitrites in dye, that is food preservatives. These are food preservatives in canned food and so on. Fungal infection that is a feature occurs commonly in immune suppressed people. Patient with organ transplant, patient on glucocorticoid therapy, patient on chemotherapy, HIV positive, hepatitis C positive. These are people with increased elderly people, smoker, poor, with low socioeconomic status. These are liable for fungal infection and complicated squamous cell carcinoma. Human papilloma virus may play. There is studies to say that human papilloma virus might play an etiologic role in esophageal carcinogenesis, either by producing carcinogens or promoters, or by acting directly on the host cells, directly on the esophageal mucosal cells. Plummer-Vinson syndrome, we mentioned this syndrome previously. Plummer-Vinson syndrome, elderly female, postmenopausal female with iron deficiency anemia and dysphagia and upper esophageal web. This is a risk factor for squamous cell carcinoma, and achalasia also. This is repeated here. Morphology, most commonly, as we say previously, adenocarcinoma of the esophagus, involving the lower third of the esophagus as a complication of long-standing Barrett, whereas the most common location for squamous cell carcinoma is the middle third. The middle third can involve the upper, can involve the lower third, but most commonly and up to 50% to involve the middle third of the esophagus. There it can be circumferential, ulcerating or fungating, with muscle invasion and extension to the underlying soft tissue and attachment to the trachea. Intraluminal growth lead to total obstruction, and distal tumor can invade the stomach, involving the lower third, can invade the stomach. But this should be differentiated from Barrett and should be differentiated from gastric mucosa involving the lower third of the esophagus. Typically, large mass in the middle third of the esophagus, fungating with central ulceration, hyperemia, and irregular margins fixed to the wall. This is typical picture of squamous cell carcinoma of the esophagus. Another picture of squamous cell carcinoma involving the lower third. This is not Barrett, complicating adenocarcinoma. It is an esophageal squamous cell carcinoma. Probably should be proved by microscopical examination of the lesion. The margin is fungating. The lesion is fungating with irregular margin here, irregular margin, central ulceration and bleeding, and adherence to the wall. You can identify the difference here between the gray, pale squamous epithelium. This is the gastroesophageal junction, nicely seen, and this is the mucus secreting or the gastric mucosa with the gastric ruges, So there will be transition from the squamous into the columnar epithelium. Squamous cell carcinoma involving the lower third, less commonly, most commonly in the middle third of the esophagus. Dysplastic changes or even carcinoma in situ here, pleomorphism, atypical mitosis or aberrant mitosis, increase in mitotic activity, pleomorphism, high NC ratio, hyperchromasia, irregular nuclear membrane. These are features of progressing from low-grade dysplasia to high-grade dysplasia, carcinoma in situ. There is no invasion till now, but there is features of malignancy like aberrant mitosis. So this is a picture of carcinoma in situ, severe dysplasia, and even carcinoma equivalent to carcinoma in situ of the lower of the esophagus. Squamous cell carcinoma, invasive squamous cell carcinoma with nests of invasive squamous cells involving here this is the non-neoplastic squamous epithelium, intact basement membrane, submucosa, muscular cord, and here the start of the tumor here. Nests of invasive malignant squamous cell epithelium invading downward into deep muscles with areas of bleeding and necrosis and high cellular proliferation. This is areas of central necrosis within their rapidly proliferating squamous cell carcinoma nests. And thank you.